Namaste Vidya, Hamesha Khush Ho Vidya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue with the infectious disease. Infectious disease, leprosy. Leprosy is also known as Hansen's disease. This disease is important from the examination point of view because this is very frequently asked in the examination. Leprosy, what is leprosy? In today's lecture, we are going to learn about the name, the definition, the etiopathogenesis, the clinical features, the investigations, and the management of leprosy. So let's start with leprosy. What is leprosy? Leprosy is a non-fatal chronic infectious disease that is caused by Mycobacterium leprae. So it is a non-fatal chronic infectious disease that is caused by Mycobacterium leprae. It is affecting the skin, the peripheral nervous system, the upper respiratory tract, the eyes, and the testes. So it is a non-fatal chronic infectious disease that is caused by Mycobacterium leprae, and it is affecting the skin, the peripheral nervous system, the upper respiratory tract, the eyes, and the testes. So 5 things are getting affected: the skin, peripheral nervous system, upper respiratory tract, eyes, and testes. Untreated diseases result in the characteristic deformities. When the disease is not treated, then it leads to the characteristic deformities. It is recognized by most cultures as communicable from person to person, and it has resulted historically in a profound social stigma. So untreated disease result in characteristic deformities. It is recognized in most of the cultures as communicable from person to person, and it has resulted historically in a profound social stigma. It is an acid-fast, obligate, intracellular bacterial species that is indistinguishable microscopically from the other mycobacteria. So it is basically an acid-fast, obligate, intracellular. So it is living only in the cells. This is a bacteria that is indistinguishable microscopically from other mycobacteria. The clinical manifestations are determined by degree of the patient cell-mediated immunity. So the clinical manifestations, these are determined by the degree of patient cell-mediated immunity. The high levels of CMI or the cell-mediated immunity with the elimination of leprosy bacilli produces tuberculoid leprosy. So tuberculoid leprosy is because of the elimination and the high levels of cell-mediated immunity with the elimination of leprosy bacilli. Whereas absence of cell-mediated immunity results into lepromatous leprosy. So when the cell-mediated immunity is good, then it will result in tuberculoid leprosy. And when the cell-mediated immunity is low, then it will result into lepromatous leprosy. The complications are due to nerve damage. So whenever there is any complication, it is due to nerve damage, immunological reactions, and bacillary infiltration. So we have nerve damage, we have immunological reactions, and we have bacillary infiltrations. Mycobacterium leprae, it grows best in the cooler tissues. Cooler tissues like the skin, the peripheral nerves, the anterior chamber of the eyes, the upper respiratory tract, and the testes, sparing the warmer areas of the skin, that is, and the axilla, the groin, the scalp, and the midline of the back. So Mycobacterium leprae, it is growing best in the cooler tissues of the body, like the skin, the peripheral nerves, anterior chamber of the eyes, upper respiratory tract, and the testes, and sparing the warmer areas of the skin, that is the axilla, groin, scalp, and midline of the back. Male is to female ratio is 2:1. So it is more common in the males as compared to females. Now the transmission. How does the Mycobacterium leprae is transmitted? The transmission takes place by nasal droplet infection, that is, the contact with the infected soil, and even insect vectors have been considered the prime candidates. The infection occurs through the nose, followed by hematogenous spread to the skin and the nerve. So there is nasal droplet infection with the contact with the infected soil, and even insect vectors have been considered the prime candidates. The infection occurs through the nose, following hematogenous spread to the skin and the nerve. The incubation period is usually 2 to 5 years for tuberculoid leprosy and 8 to 12 years for the lepromatous leprosy. So incubation period for tuberculoid cases, we have 2 to 5 years, and for the lepromatous case, it is 8 to 12 years. Now, what are the clinical features? Clinical features depends upon the type of leprosy by which the patient is getting affected. There are 3 types of leprosy that we are going to see. One is tuberculoid, the next one is the lepromatous, and the third one in between, that is known as borderline leprosy. So the first one is tuberculoid, second is borderline, and the third one is the lepromatous leprosy. So what happens in tuberculoid? First of all, we are going to discuss about the tuberculoid leprosy. Tuberculoid leprosy, it is less severe and of the disease spectrum because it results because of the cell-mediated immunity. Tuberculoid leprosy results in the symptoms that are confined to the skin and peripheral nerves. So the symptoms are confined to the skin and peripheral nerves. One or severe hypopigmented macules with plaques with sharp margins that are hypoaesthetic and have lost sweat glands and their hair follicles are present. Acid-fast bacilli are few or absent. So tuberculoid leprosy, it is less severe and it severe end of the disease spectrum. And tuberculoid leprosy results in the symptoms that are confined to the skin and peripheral nerves. One of the severe hypopigmented macules or plaques, which with the sharp margins that are hypoaesthetic and have not sweat glands and hair follicles are present. Acid-fast bacilli are few or absent. There is asymmetrical enlargement of one or the following peripheral nerves. It is most often on the ulnar and posterior auricular, peroneal, and posterior tibial nerves. That is associated with hyperesthesia and myopathys. Second variety is lepromatous leprosy. Patients with the lepromatous leprosy develop symmetrically distributed skin nodules. So there are development of skin nodules, and the symmetrical skin nodules are developed with raised plaques and diffuse dermal infiltration that can cause leonine facies. So in lepromatous leprosy, we have leonine facies, loss of eyebrows and eyelashes. There is pendulous earlobes and dry scalings. There are numerous bacilli that are present in the skin and up to 109 per gram. The nerves and all organs except the lungs and CNS are affected. The nerve enlargement and damage are usually symmetrical and due to bacillary invasion. So in the lepromatous leprosy, the patients develop symmetrical distribution of the skin nodules, raised plaques, and diffuse dermal infiltration that can cause leonine facies. There is loss of eyebrows and lashes and pendulous earlobes and dry scaling. There are numerous bacilli that are present in the skin up to 109 per gram, nerves and all the organs except the lungs and CNS. So except the lung and CNS, it is getting affected. Nerve enlargement and damage are usually symmetrical. So whenever there is nerve enlargement and damage, it is usually symmetrical and due to bacillary invasion. Borderline leprosy. Borderline leprosy or the borderline tubercular, it is of 2 types, borderline tuberculoid and borderline lepromatous leprosy. So borderline tuberculoid BT cases, the skin lesions are more numerous than the So we were discussing about the borderline leprosy. In the borderline tuberculoid leprosy, BT cases, there are skin lesions that are more numerous than the tuberculoid leprosy. And there is more severe nerve damage and risk for type 1 reactions. So in case of borderline tuberculoid leprosy, we are seeing skin lesions that are more numerous than the tuberculoid leprosy cases, and there are more severe nerve damage and risk of type 1 reactions. Whereas in borderline leprosy, BB cases, the skin lesions are more numerous and vary in size, shape and distribution, and there are annular lesions that are characteristics and the nerve damage is variable. In borderline lepromatous cases, there are widespread small macules in the skin and widespread nerve involvement, both type 1 and type 2 reactions. Pure neural leprosy, that is without any kind of skin lesion, occurs principally in India and occurs for 10% of the cases. There is asymmetrical involvement of the peripheral nerves, trunk with no visible skin lesion. The clinical features. The clinical features depends on the site where it is affected. It will be completed in terms of skin lesions, anesthesias, and nerve damages with the eye involvement and other features. So let's start the clinical features with the skin features. In most of the common skin lesions are macules or plaques. In tuberculosis, so there are two types of important skin lesion, that is macules and the plaques. In tuberculosis patient, we have few hypopigmented lesions. The Leprosy leprosy, papules, nodules, or diffuse infiltration of the skin occurs. The earliest lesions are ill-defined and gradually the skin becomes infiltrated and thickened. The facial skin thickness leads to the characteristic leonine facies. Second variety, we have anesthesia. In anesthesia, the skin lesions are small, dermal, sensory and autonomic nerve fibers that are damaged, causing local sensory loss and loss of sweating within the area. There is anesthesia, which may also occur in the distribution of the damaged large peripheral nerve. A glove and stocking sensory neuropathy is also common in leprosy. So in the skin lesion, it is the most common type of lesions are macules and plaques. In the tuberculosis patient, we have few hypopigmented lesions, and in leprosy, the papules, nodules, or the diffuse infiltration of the skin occurs. The earliest lesions are ill-defined, and gradually the skin becomes infiltrated and thickened. The facial skin thickening leads to the characteristic leonine facies. Anesthesia, the skin lesions are small dermal sensory autonomic nerve fibers that are damaged, causing local sensory loss and loss of sweating within the area. So there is loss of sensation and loss of sweating. Anesthesia may also occur in the distribution of a damaged large peripheral nerve, a glove and stocking sensory neuropathy, and it's also common in leprosy. There is also nerve damage. Nerve damage that occurs in peripheral nerves, nerve trunks, it is affected at the site of predilection. These are the ulna, elbow, median. Ulna, we have elbow. Median, we have wrist. Radial, we have humerus. And radial cutaneous wrist. Common peroneal, that is occurring in knee. Posterior tibial and sural nerve, ankle nerve, with facial nerve, that is zygomatic arc, and great auricular nerve with a posterior triangle of the neck. Damage to peripheral nerve trunks produces characteristic signs with regional sensory loss and muscle dysfunctions. There is also eye involvement, with the blindness is a devastating complication for the patient with anesthetic hands and feet. The eyelid's closure is impaired when the facial nerve is affected, and the cornea is then susceptible to trauma and ulceration. So in the eye involvement, there is blindness, that is devastating complication for the patient with anesthetic hands and feet. Eyelid closure is impaired when the facial nerve is affected. The cornea is then susceptible to trauma and ulcerations. Other features includes nasal collapse, occurs secondary to the bacillary destruction of the bony nasal spine. There is diffuse infiltration of the testes causing testicular atrophy and acute orchitis that occurs with type 2 reactions. It results in azoospermia and hypogonadism. There are also leprosy reactions. There are two types of reaction, type 1 reaction and type 2 reaction. In type 1 reaction, it is also known as the reversal reaction. It occurs in 30% of borderline patients with BT, BB, or BL, and are delayed hypersensitivity reaction. So type 1 is basically delayed hypersensitivity reaction, with the skin lesions becoming erythematous. Peripheral nerve becomes tender and painful, with sudden loss of nerve function. In type 2, we have erythema nodosum and leprosum, that is ENL reactions. These are partly due to immune complex deposition and occurs in BL and LL patients who have antibodies and that have high antigen load. They manifest with malaise, fever, crops of small pink nodules on the face and limbs. There is iritis and episcleritis. The other signs of acute neuritis, lymphadenitis, orchitis, bone pain, dactylitis, arthritis, and proteinuria. In the borderline cases, the skin lesions are more numerous than the tuberculoid lesions. Now we come to the investigations. What are the various investigations that could be done in case of leprosy? So the diagnosis is clinical and is made by finding the cardinal signs of leprosy and supported by the finding acid-fast bacilli in slit skin smears or typical histology, and skin biopsy. There is slit skin smear are obtained by scraping the dermal material on the glass slide. The smears are useful for confirming the diagnosis and monitoring response to the treatment. So the diagnosis is clinical and is made by finding the cardinal signs of leprosy and supported by finding acid-fast bacilli in slit skin smear or typical histology in skin biopsy. The slit skin smear are obtained by scraping dermal material on the glass slide. The smears are useful for confirming the diagnosis and monitoring response of the treatment. The treatment consists of rifampicin. It is the only agent bactericidal against Mycobacterium leprae. Clofazimine is a phenazine iminoquine dye that is weakly active against Mycobacterium leprae, and monotherapy with dapsone. So in the treatment, we have rifampicin, that is only agent antibacterial against Mycobacterium leprae. We have clofazimine is a phenazine iminoquine dye that is weakly against the Mycobacterium leprae, and monotherapy with dapsone. So this was all about leprosy. In the next lecture, we are going to discuss about another important topic related to the infectious disease. So let's give a quick revision of the leprosy. What is leprosy? Leprosy is a non-fatal chronic infectious disease caused by Mycobacterium leprae that is affecting the skin, the peripheral nervous system, the upper respiratory tract, the eyes, and the testes. The untreated diseases results in characteristic deformities, and it is recognized in most of the cultures as communicable from person to person. They have resulted histologically and a profound social stigma. Mycobacterium leprae is an acid-fast obligate intracellular bacteria species, indistinguishable microscopically from other bacteria. The clinical manifestations are determined by degree of patient cell-mediated immunity. There are high levels of CMI with elimination of leprosy bacilli produced by tuberculoid leprosy. Whereas the absence of cell-mediated immunity results in lepromatous leprosy. The complications are due to nerve damage, immunological reactions, and bacillary infiltrations. Mycobacterium leprae grows best in the cooler tissues like the skin, peripheral nerves, anterior chamber of the eye, and upper respiratory tract and testes, sparing the warmer areas of the skin like the axilla, groin, scalp, and midline and back. Male is to female ratio is 2:1. The transmission takes place by nasal droplet infection with a contact with the infected soil, and even insect vectors, they have been considered as the prime candidates. Infection occurs through the nose, followed by hematogenous spread in the skin and the nerve. The incubation period is, in case of tuberculoid cases, it is 2 to 5 years, whereas in lepromatous cases, 8 to 12 years. The clinical features depend on the type of leprosy, which is divided into tuberculoid, borderline, and lepromatous. The tuberculoid leprosy, at the less severe end of the disease spectrum, it is result in the symptom confined to the skin and peripheral nerves. One of the severe hyperpigmented macules or plaques with the sharp margins that are hyperesthetic and have lost sweat glands and hair follicles are present. Acid-fast bacilli are few or absent. These are asymmetrical enlargement of one or several peripheral nerves, most often the ulnar, posterior auricular, peroneal, posterior nerve associated with hyperesthesia notably. In lepromatous leprosy, the patient develops symmetrical distribution nodules that have raised plaques and diffused dermal infiltration that are causing leonine phases, loss of eyebrows, eyelashes, and pendulous eyebrows at early dry scaling. In the borderline leprosy, we have skin lesions are more numerous than the tuberculoid leprosy and is more severe nerve damage at the type 1 reactions. In borderline leprosy, skin lesions are numerous of varying in size, shape, distribution, and inner lesions and are characteristic, and nerve damage is variable. In borderline lepromatous cases, there are widespread small macules in the skin and widespread nerve involvement. Both type 1 and type 2 reactions occur. Pure neuronal leprosy, that is without skin lesions, occur principally in India and accounts for 10% of the patients. It is asymmetrical involvement of the peripheral nerve trunks and no visible skin lesions. The clinical features depends on the presence of skin lesions with macules, plaques. Tuberculoid patient have hyperpigmented lesions. Lepromatous leprosy have papules, nodules, or diffuse infiltration of the skin, and they are ill-defined. Gradually, the skin becomes infiltrated and thickened. The facial skin thickening leads to characteristic leonine phases. Anesthesia is present with the skin lesions of the small dermal sensory and autonomic nerve fibers are damaged. Anesthesia may occur in the distribution of damaged peripheral nerves. There is nerve damage with peripheral nerve trunks that are affected at various sites. eye involvement, which includes blindness, that is devastating complication of the patient with anesthetic hands and feet. Eyelid closure is impaired and the facial nerve is affected. There are other features which includes nasal collapse that occurs secondary to the bacillary destruction. Leprosy reactions, we have two types of leprosy reaction. We have type 1 and type 2 reaction. Type 1 is also known as reversal reaction, and type 2 is erythematous nodosum leprosy. In type 1, we have borderline patients. There is delayed hypersensitivity reaction and skin lesion becomes erythematous. In type 2, we have it occurs in borderline and erythematous leprosy and manifest as malaise, fever, crops of small pink nodules on face and lips. The investigation consists of clinical findings. The diagnosis is clinically made on the practical or the clinical aspect by checking for the symptoms. The skin slit smear can be obtained, and smears are more useful in confirming the diagnosis and monitoring the response of treatment. The treatment consists of rifampicin, clofazimine, and monotherapy with dapsone. So this was all about leprosy. I hope you have understood this session properly. If you have any query, you can refer my notes, e-notes, and the other study material that I have uploaded on the portal. So this was all for today. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. If you have any query or if you have not understood anything, then please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.